Okay, so good morning everybody and welcome to this morning's Muscles Matter 2021 online seminar on spinal muscular atrophy focusing on children. Building on the success of our 2020 series and having taken feedback into account, our Muscle Matters seminars have become a regular feature in our calendar at MDUK. They won't replace our live events, but we'll run alongside them when we're able to host those again and bring people together in person. We're running 2 or 3 seminars a month, focusing on a range of general and condition-specific topics. And they include sessions that you told us you found the most useful on research, practical and financial support, and managing your condition. Our helpline remains available to anyone affected by muscle wasting conditions, and do please contact us if you have any questions or are in need of support. We can help you with information and can either support you directly or point you to where you can get the support you're looking for. The number and email address should be on the screen, and you can call us on 0800 652 6352 or email info@musculardystrophyuk.org. This morning, we're very grateful to be joined by an expert panel covering a broad range of expertise on spinal muscular atrophy. And we're also very grateful for the support of our sponsors this morning, PTC Therapeutics, Roche and Novartis. We're splitting the session into 3 parts and we'll begin by looking at research and then move to treatments that are currently available before exploring living with and managing the condition. Before we begin, a note on how you can ask questions or make comments. We've had some advanced questions and we'll seek to cover these as the session develops. And we'd also like to incorporate some live input. To do this, we'll be using the Q&A function. So please type your questions or comments into the Q&A function and we'll feed them into the discussion. To help us manage the technical side of the event, we won't be calling on questioners to ask their questions directly. Any questions we don't manage to cover or that we need more information to help you with, we'll seek to answer after the session. And finally, a reminder that we're recording the session and it will be made available over the next few days. So to start us off this morning, I'm delighted to hand over to my colleague, Dr. Kate Adcock, who will introduce our research speakers and then chair that part of this morning's session. Kate, over to you.
Thank you, Rob, and good morning to everyone. I'm delighted to introduce 2 great speakers to you for the research session this morning. Firstly, Dr. Melissa Baumann, who is a lecturer in bioscience at the School of Medicine at Keele University. After completing her PhD at the University of Ottawa, she moved to Europe, first to Montpellier in France, and then to the University of Oxford, where she worked as a postdoctoral researcher. She's been at Keele now, I guess, for a little over 3 years. Melissa's research interests are focused on identifying pathways that cause neuromuscular conditions such as spinal muscular atrophy, and she carries out studies to look at ways of treating these in her research. Alongside Melissa is Sam Fitzsimmons, who is a clinical trial coordinator at the John Walton Muscular Dystrophy Research Centre at Newcastle University. Sam helps to set up and coordinate clinical trials, as well as working with teams involved in the SMA Reach and adult SMA Reach, and you'll hear a lot more about those in a few moments. Both Sam and Melissa have kindly prepared videos of their talks, and we'll hear first from Melissa about her research, and then Sam and another colleague in London have prepared talks on the SMA Registry and SMA Reach. After the videos, there will be time for questions, so please do use the Q&A function that Rob mentioned earlier. So first of all, we'll hear from Melissa. Thank you.
Hi everyone, my name is Melissa Bowerman. I'm a lecturer in bioscience at the School of Medicine at Keele University, and it really is my pleasure to be here today to share with you an update of the lab-based research that we do here in the lab at Keele University. So our research is aimed at answering 2 overarching questions. The first one being is how are SMN therapies, and here we're talking about Spinraza, Zolgensma, and Risdiplam, how are they changing the different tissues and cells that are affected in SMA? Are they improving them perfectly, or are there still defects that remain after SMN treatments? So really, what is restored and what is not? And really the follow-up question to that is, what new treatments that are non-SMN can we develop to restore this? And really the kind of follow-up question from this is, can we combine treatments with different functions to improve several health outcomes at the same time? So here we're not trying to replace the SMN therapies. They're brilliant, they're life-changing, they're life-saving, and we're really grateful for them. But can we actually make them better by combining them with additional drugs and treatments? And in the lab, we use two strategies. So the first strategy being drug repurposing, so reusing drugs that are currently being used in other conditions, but that could benefit SMA. And our second strategy are dietary interventions. So how can we use our diets to improve symptoms in SMA? And really, it's important to highlight that we're looking at SMA as a whole body disease, whereby different cells and tissues in the body are impacted, and how can we restore them with our different strategies. So our first strategy is drug repurposing. So what we do in the lab is we take tissues and cells from SMA models, and in our lab, we mostly use SMA mouse models. And we take these tissues and cells and we try to identify genes, so pieces of DNA, proteins, and the pathways that they regulate that are abnormal, that are not normal compared to healthy animals. And we have human samples, human cells as well. And what we do is once we've identified these genes and proteins and pathways that are aberrantly expressed, so we use that through different bioinformatic approaches, so using computer softwares. Then what we do is we identify commercially available drugs that are known to improve these abnormal genes and proteins and pathways. And some of that criteria that we use are safe in children, administered orally, for example, and we also look at cost and accessibility as well when we choose these drugs. Now, these drugs have never been tested in SMA, so we started evaluating them in cell and animal models. And then the overall goal of this is, because these drugs have already been approved and used in other conditions, this will lead to shorter clinical trial periods and increased potential of success and approval for SMA patients. So we've previously demonstrated the validity of this approach. So up top is a paper that we published in 2018. And more recently this year, we've published the second paper at the bottom. Those are open access, so you can Google them and access them and read them if you like. And both of these studies were supported by Muscular Dystrophy UK using this approach of drug repurposing, where we were able to show strong benefits of the drugs that we decide to investigate in SMA animal models. Now, our current project that still follows this strategy is entitled Therapeutic Potential of a Glucocorticoid Receptor Antagonist for the Treatment of Spinal Muscular Atrophy. This is a project that's co-funded by Muscular Dystrophy UK, so studentship that supports Emma Sutton right here, who leads this project, Action Medical Research, as well as SMA UK. And the basis of Emma's project is based on glucocorticoids, which are hormones that we all produce. And these glucocorticoids, when they are produced, will bind to a receptor, so another protein. And once they bind together, they lead to the unhealthy increased amounts of KLF15 in SMA. So in SMA, we have an increased activity of this glucocorticoid receptor, KLF15. That makes tissues and cells abnormal in their function, if you want. So we've previously demonstrated that KLF15 is increased, so there's abnormal increased amounts in skeletal muscle, in heart, in spinal cord, and in fat tissue and adipose tissue as well. So what we want to do is decrease that activity. And to do that, we're employing a drug that actually inhibits the binding of glucocorticoids to its receptor. So if you have a drug that inhibits the interaction between glucocorticoids and its receptor, then you don't have this unhealthy increased amounts of KLF15. And so this drug is called mifepristone. And Emma's been working really hard testing it in cells and animal models, whereby we've tested mifepristone by itself, identified a dose and a timing at which we have improved benefits in SMA mice, and we've just started to now try to evaluate it with an SMN gene therapy to see if we can improve both the effects of both drugs when they're applied together. And so by inhibiting this GC, glucocorticoid receptor, and KLF15 pathway, we're really seeing improved disease phenotypes within skeletal muscle, within other metabolic tissues. So we're also looking at fat and heart, for example. We're seeing improvement in weight and in lifespan of our animals. What's really interesting from this study is we found that actually it's treating later during the life of the animal is better, which is very promising in the sense that actually our study shows that you can use a non-SMN therapy later in disease progression that leads to significant benefits in the mice, at least. So this is ongoing, but we've got exciting results, and we're very thankful to MDUK for supporting this research. I've said we also look at dietary interventions. So ourselves and others have demonstrated altered metabolism in SMA patients, and really how that might have implications on nutritional management in SMA patients. So when you think about glucose, or your sugars, your amino acids, your fat, and your fatty acid, and your lipid metabolism, these have all been demonstrated in one way or another to be altered in SMA patients. So this is all metabolic pathways that are impacted by what we eat, but also how what we eat is used and utilized in our body. So if these metabolic pathways are altered, it makes sense that whatever we feed our body will influence these metabolic pathways. So it might make them better, might make them worse, or might help stabilize them. At the same time, these altered metabolic pathways in the food that we eat will have different impacts on different metabolic tissues, so tissues whose function are really impacted by what we eat and how what we eat is used. So it's really something that we're trying to better understand in the context of SMA. In particular, in the lab, we're really interested in branched chain amino acids, which are abbreviated to BCAAs. Now, BCAAs come from our diet, so we don't produce them naturally. They come from meats, for example, cheese, but you can also buy supplements at various shops, for example. So weightlifters take BCAAs a lot to supplement their workouts. And so these BCAAs, there are three. They're called valine, isoleucine, and leucine. Those are amino acids, and they'll circulate through our blood once they've been absorbed from our diets. And in skeletal muscle, so in our muscle, they will be used to regulate glucose metabolism, lipid metabolism, make new proteins that are required as well to make muscle and maintain muscle. So they're quite important for muscle health, the BCAAs. And we and others have previously shown that BCAAs are really low in the blood of SMA models and patients compared to healthy counterparts, but also that giving BCAAs to mice improves SMA disease progression. So one of our current projects is investigating the amino acid diet in SMA patients. And I showed this graph at the MDUK National Conference 2 years ago, when I was asked to discuss kind of the future of neuromuscular research, where I said that we really needed to collaborate more between industry, clinicians, fundamental researchers as myself, and patients and families. And I really like this project because it's really come full circle in the sense that this project that we're currently undertaking does follow this model I proposed 2 years ago. So myself, and my lab and my collaborators, we've done a lot of work on amino acid diets in SMA mice, and have been a big voice in the importance of them in SMA. And that led us to collaborate with clinicians and dietitians at UCL Gosh. And together we had a few workshops that consisted of Anne McGuire and Mary Bodzo. Mary Bodzo, some of you may know of her, who lives in the United States and developed the amino acid diet that a lot of people across the world follow, a lot of SMA families follow. And in collaboration with MDUK, SMA UK, and Treat SMA, the workshop, we also invited other families within the UK to discuss and develop our study. And then we're collaborating with Nutricia, who are financially supporting this study of a pilot study of the amino acid diet in SMA patients. So I'm very happy that it's been a lot of work, but we're here. I should mention that it's a small pilot study. So we're only looking at a small number of patients, and it will be type 1 patients for the time being. But our goal is to expand eventually to multi-centered and to older type 2 and type 3 patients as well. And in parallel to the patient work, we're also continuing the animal work. And so, for example, in parallel to the previous study mentioned in collaboration with Gosh, we're also looking at the amino acid diet in SMA mice, because in mice we can gain more mechanistic insights and therapeutic insights than we can in patient disease. So, for example, we can better understand the individual contribution of each component of the AA diet. So the AA diet is based not only on branched chain amino acids, but also on fat content and carbohydrate content. And so in animal models, we can actually separate those three components and look at them individually and together. We can look at longitudinal effects in mice better than we can in a pilot study in patients. So that means that at several time points over disease progression, we can actually look at what's happening in the blood and in different cells and in different tissues. And actually, then we can start looking at the combined effect of the diet with an SMN therapy. We're doing that in parallel to the patient study. And secondly, we're comparing BCAAs versus leucine versus HMB. And to explain that, the BCAA supplement that we gave to the mice that improved their disease progression are really composed of all three BCAAs. So you've got, for every 2 leucine, you've got 1 valine, you've got 1 isoleucine. However, we know from others and their research that of the 3 BCAAs, leucine is the one that acts the most on muscle and muscle health. And within leucine, it's this metabolite that it produces, abbreviated to HMB, that has the most impact on muscle health. And so really what we want to better understand in terms of the effect of BCAAs in SMA is, could we improve or maximize the benefits that we saw with the BCAAs if we actually supplemented the diet with leucine or HMB instead? So this is ongoing in the lab as well. So that was a brief tour of what we're currently doing in the lab. Please don't hesitate to contact me if you have further questions. I'm always happy to share with you what we're doing in the lab. And obviously, none of these projects would be possible without lab members, current and past at Keele. All our collaborators, whether they're in the UK or international, and really all our funders that have supported previous and current work on SMA, and with whom we wouldn't be able to do any of this. And thanks to you for being here, listening, and supporting us as well. Thank you.
That's brilliant. Thank you for that really great and insightful talk, Melissa. We'll move on to the next video so that we can keep the momentum going, which will be from Sam. Through the miracles of the internet, we have the next video. That's going to be about the SMA registry. So Kat, if you can switch over to that video, that would be fantastic. Thank you.
An overview of the UK SMA Patient Registry. My name's Samantha Fitzsimmons. I'm a clinical trial coordinator at the John Walton Muscular Dystrophy Research Centre, where this registry is hosted, and I will be giving this presentation on behalf of Lindsay Murphy, the registry curator. The registry was created in 2008 and is a patient-initiated, patient-reported online registration that requires consent of the participant to collect patient-reported data from residents throughout the UK and Ireland. The registry was established with EU funding from Treat NMD and further funding from the Jennifer Trust and SMA UK, with current funding from Biogen under the Adult SMA Reach project. The registry currently collects current and longitudinal data on an annual basis and includes the minimal original Treat NMD standardised core dataset. The registry is able to share data with SMA Reach UK and is pending approvals to share data with Adult SMA Reach. Currently, there are 730 patients participating in this registry. This slide gives an overview of the patient journey within the registry, from initiating registration to consent to the annual request of patient-reported outcome measures via questionnaires. The role and impact of the UK SMA Patient Registry is to provide a source of information to academics, healthcare professionals and industry to support research on the natural history of the condition and support the development of standards of care. The registry responds to feasibility and recruitment inquiries from industry as an individual registry and as a member of Treat NMD Global SMA Registry. It aids the rapid identification of eligible patients for clinical and research studies and disseminates relevant SMA-related information to registry participants, as well as supporting the SMA community. The general consensus is for a single registry for data collection to be used per country. In this slide is demonstrating how the UK SMA Patient Registry, SMA Reach UK and Adult SMA Reach fit together. The UK SMA Patient Registry is a patient-initiated registration, patient-reported platform. It's an active choice for a participant to be involved. They can control the data, and it's also a platform where the patient voice is captured. It's available to all UK and Ireland residents and is independent of clinic, including patients that are no longer seen in clinic. It is part of the Treat NMD Global SMA expanded dataset and is a communication tool and ideal for the collection of PROMs. SMA Reach UK and Adult SMA Reach is a clinical database for natural and treatment data and is clinically reported. The patient must attend a neuromuscular clinic that is part of SMA Reach UK or Adult SMA Reach network in order for this data to be recorded. The networks are actively expanding, however, the cover is incomplete. And the aim for this is that a participant will agree to participate in the UK SMA Patient Registry, SMA Reach UK and or Adult SMA Reach, and the data will be shared. So patient-reported outcome measures will be shared with the clinical platform, and the clinical data will be shared back to the patient via the UK SMA Patient Registry. This therefore gives a full oversight, not only of the clinical data, but how the patient is managing with their condition on a day-to-day, providing a full overview. Lindsay Murphy is the registry curator for the UK SMA Patient Registry, and if you have any questions about this presentation or the registry, please feel free to contact Lindsay at this email address. Thank you.
Brilliant. Thank you very much for that presentation, Sam. And people feel free to contact Lindsay at any time if you'd like to join the registry, if you haven't already. It's a great opportunity for your views and your experiences to feed into the whole sort of data around SMA. So next we're going to hear... Sorry. Next we're going to hear from the SMA Reach project that Sam has already mentioned. So Kat, if you can switch over to that video, that would be great. Thank you.
Hi, am going to present a summary of SMA Reach UK, and I am Salma, the trial manager of the study. So, some background and aims. SMA Reach UK was set up really to establish a national agreement on the clinical and physio assessments and standards of care. All data is collected within usual SMA clinics. Secondary aim was to utilize a database and a longitudinal data warehouse where data is collected and data has been audited and reviewed, and there have been publications that have arisen from this. So we are based at UCL as well as Great Ormond Street, and we work in conjunction with Newcastle University, who are our long-standing collaborators. SMA Reach is also part of the ISMAC consortium, so that's the International SMA consortium, along with two other networks, the PMCRN in the States and the Italian network. The consortium itself was contacted by Wraige with a strong interest in collecting anonymized natural history data on the entire spectrum of SMA severity from routine clinical visits. So the main data to be collected includes medical information and physiotherapy assessments. These were agreed across the three networks, and the data is currently collected on extended data sets, and this has been ongoing since 2018. So within the UK, we have 7 centres collecting this data on this, which is shared with Wraige and upon patient consent, of course. Further to that, SMA Reach was chosen by NICE NHS England to be part of a managed access agreement with regards to nusinersen. This started in 2019. Well, the agreement was signed off in 2019 and data collection began in 2020. We've just submitted our second data cut. In addition to that, pseudo-anonymized data shared with Wraige for post-marketing surveillance, again, all upon patient consent. So currently we have nusinersen, which is an approved treatment, and now we have Zolgensma, and risdiplam is within the final stage to be approved. So the network is in talks with Roche and Novartis with regards to a potential collaboration to share data as part of post-marketing surveillance. In terms of COVID and the impact on SMA Reach and data collection, so we have a number of centres across the network, and I contacted the centres with regards to assessing the impact of COVID. And so I'm just presenting a brief summary that this was presented at the last NICE MOC meeting. So really the main themes to take away were that rather than any missed nusinersen doses, patients, these were delayed rather than missed. And again, this was due to COVID. Other take-up points were the fact that the majority of the assessments were conducted remotely and with a phased introduction to face-to-face appointments at a later point in line with COVID rules within the local trust. The majority of the assessments were medical. These were done via phone consultations. Video assessments, physiotherapy assessments were also conducted, especially during the peak of the second wave. In terms of other COVID impact, we did see find reports of staff isolating due to COVID, redeployment to work on other COVID studies and research. There was an effect in terms of children, being fragile respiratory-wise and not being able to visit clinics. So it did have an impact, not just in terms of the SMA Reach data collection, but all across the board. And there was one comment from a site. This was that issues were mainly due to capacity around COVID, and contacting patients to do remote assessments was difficult. So in terms of upcoming studies, we do have a number of SMA studies in the pipeline at Great Ormond Street. These include gene therapy and device trials. And if anyone's interested, feel free to contact myself for any further information. Thank you very much.
Brilliant. That's great. Thank you very much, Salma, for remotely joining our session, which is pretty cool now with this technology. Finally, for this session, there's one final video on the adult SMA Reach, which is sort of a much newer endeavour that Sam is going to talk to us about. So, Kat, if you can cue up the video, we'll hear that now too. Thank you.
This is an overview of adult SMA Reach. My name is Samantha Fitzsimmons, the Clinical Trial Coordinator, and I'm based at the John Walton Muscular Dystrophy Research Centre. In collaboration with our colleagues at UCL and SMA Reach UK, along with the UK SMA Patient Registry, this study will collect clinician-entered vital natural history and treatment data, meeting an urgent need to build knowledge and gain a better understanding of adult SMA. The aim is to develop and implement a standardised data set and data collection in the adult SMA population, leading to a better understanding of the history of adult SMA. The project will include safety monitoring for patients accessing new treatments under managed access and early access schemes, establish a connectivity between the UK SMA Patient Registry and the adult SMA Reach platform to correlate patient-entered with clinical-entered data. It will audit an implementation of standards of care and service development, as well as implementing new functional skills. The project is funded by Biogen and sponsored by the Newcastle upon Tyne Hospital's NHS Foundation Trust in collaboration with Newcastle University. This slide is a visual representation of how SMA Reach UK and adult SMA Reach are working in collaboration. There is a parallel protocol in all clinical entered data where we entered into the CERTS database and the UK SMA Patient Registry. Once a participant in SMA Reach UK reaches the transition stage for adulthood, they will be offered the option to consent to adult SMA Reach, where we can continue to collect the natural history and treatment data for those participants. 17 sites have agreed to participate in adult SMA Reach across England, Scotland and Wales, and we are in discussion with a further 3 sites regarding participation in this project. One of the aims for adult SMA Reach is to form a connectivity between the UK SMA Patient Registry and adult SMA Reach. In order for this to happen, a patient will need to consent to adult SMA Reach and the UK Patient Registry. From that, we would like to collect the patient-reported outcome measures that are collected via the SMA Patient Registry, which will then feed into adult SMA Reach UK, and for the clinician-entered data to feed back into that participant's patient registry profile. There is currently a pilot underway with a couple of paediatric and adult sites trialling this before it will be rolled out into the project. This slide shows the adult SMA Reach project team here in Newcastle, led by Dr. Chiara Marini Bertolo, who is the project chief investigator and also the local principal investigator for Newcastle. As well as adult SMA Reach, this team also works on SMA Reach UK, as Newcastle are a participating site in this project. If you have any questions about this project or presentation, you can get in touch at the email address below, or you can contact me directly. For up and coming trials at Newcastle, we do have some SMA trials in the pipeline, gene therapy and device trials, and we are also in early contact regarding a CTIMP trial. If you have any questions about those, you can get in touch with me directly or via the email address on the centre website. Thank you.
Fantastic. Thank you for those videos and preparing those talks in advance. That's really great and really informative. I have a couple of questions. One for Melissa. you've mentioned that you've got a very early pilot study looking at the nutritional research that you're doing. With the other sorts of studies, so with the repurposing drugs that you're talking about, how quickly can a study get from being in your lab, so to speak, to becoming something that perhaps could be into a clinical trial and then in patients, do you think?
Yeah, so a way to answer that is it's thought, if you look at general literature, that by repurposing drugs, by using drugs that already exist, you're cutting the time in the clinic and to the clinic by 5 to 10 years on average, compared to in general when you're doing a new drug. So that would be the typical answer. In the lab, it takes us 1 to 2 years, sometimes 3, to kind of get the data out and available for everyone else. The trickiest thing is then, because we're a preclinical lab, is initiating that follow-up collaboration with the clinical team that's really ready to embark on the clinical trial.
Mm-hmm. Super, thank you. And so, yes, so that's the next important part in the process then, is to work with clinicians who would then go through all of the regulatory necessities. And it is important, obviously, that there isn't just, you know, something that somebody tries in someone without getting all the regulatory approval to then do the thorough testing in patients or in people living with a condition.
Yeah, absolutely.
Great. Super. Thank you. That's very helpful. And then Sam, questions that sometimes people ask around the registries and the databases, which are fantastic, collecting all of this wonderful data about patients and the treatments that they're on and their experiences. But who has access to that data? Who can see that information?
So only the lead project team can see the information. It will not be made available to other researchers or industry. They will be never given direct access. So researchers in industry can make a request to help facilitate planning and recruitment into a clinical trial or a research project. But all requests are reviewed by the steering committee of the registry to ensure they meet the registry objectives. But the data that will be given will always be anonymous, aggregated data for the purposes of recruitment.
Fine. So it's you would never be able to sort of pinpoint a piece of data and identify that as belonging to an individual. It's all part of a kind of a collective amount of data. So you could never identify anyone.
Yeah, you could never identify anyone.
Brilliant. Super. Thank you. And in the work that you talk about, Melissa, clearly, you know, collaboration is really important, and the same obviously with Sam, because, you know, you need to collect data from a lot of different places and collaborate with lots of people. How important is that for SMA research? Maybe Melissa, if I can go to you first.
Yeah, it's extremely important. So I've been in the field for 16 years now, and so and it's only in the last 5 years that I've really developed these clinical bridges. So I'm learning slowly, but it is so important, because sometimes, or most of the times, we don't go to the same meetings or the same conferences. And so preclinical researchers do a lot of work that's interesting, and it doesn't necessarily reach the people, the clinicians and the dietitians that we want to be reached. So it's really our job, actually, as preclinical researchers, to make that step. And I think organizations like yourselves, for example, are really a nice conduit to that, to really you know, make us collaborate and discuss our results to bring that to the clinic. Absolutely.
And Sam, for the work that you do and the teams that you work with, presumably collaboration is key.
Yes, it's so important. And a lot of sites spread out the UK don't actually have a high volume of patient numbers. So it is important that we collaborate to get strong, meaningful data.
Brilliant. Super. Thank you. Now, in a slightly unusual way for these meetings, I see that one of the panelists has their hand raised up. So before introducing her, which I will do in a moment, Liz, you have a question.
Thanks, Kate. Liz Ryburn from SMA UK, patient organisation. I just wanted to say how good it has been for us to be involved with Melissa's work, and similarly SMA Reach and the Patient Registry. I mean, there is so much going on, and I confess it was really refreshing to have that talk from you, Melissa, because we can lose sight of that with all the SMN therapy drugs that are going on and the excitement of that. But I think your initiative and the way you're bringing people in on all those projects is absolutely excellent. And I know, Kate, you and I often meet on meetings with these groups, and it's really very positive.
Absolutely, absolutely, yeah. And you're right. I think it's, you know, yes, there are some treatments out there already, and that's wonderful, but we shouldn't ever sort of rest on our laurels, so to speak, to assume that that's that box tick to move on, that there's still opportunity to enhance and the treatments that are available. So yeah, absolutely fantastic and great. Now I'm just checking the other questions that we have received in the chat and in the Q&A. I think most of those probably relate more to treatments. So I don't think that we have any other questions for the researchers per se. But if you would like to stay with us, we'd be delighted, because I'm sure that there will be things that you will find interesting in the next sessions. So without further ado, thank you to Melissa and to Sam for all of your fantastic insight this morning. We'll move on now to hear about treatments. I think it's a great segue from the research to treatments. And it is so exciting to be actually talking about treatments for SMA. It's obviously only in the last very few years where we've had treatments available, but it is a complicated landscape, and we have some people who are going to really help to hopefully explain and uncomplicate some of the landscape. So I'm really delighted that we have Dr. Elizabeth Wraige and Liz Ryburn, who you've heard from already, from speaking with us this morning. So Dr. Wraige completed her medical training at Guy's Hospital, having first completed a degree in microbiology at Leeds University. And in her clinical training, she followed her two main areas of interest. That was paediatrics and neurology. And so completed her training as a paediatric neurologist at Guy's Hospital in 2002. And she has a particular interest in neuromuscular disorders. And as a consultant, she has co-led the clinical neuromuscular service at the Evelina London Children's Hospital and facilitated the delivery of new therapies, including Spinraza or nusinersen, and has most recently established an infusion service for the delivery of Zolgensma, the gene therapy for SMA. And we'll hear from Elizabeth in a moment. And as you've heard already from Liz Ryburn, she's a support team manager at SMA UK, and has been with the organisation since May 2011. SMA UK has been providing information and support to families and supporting research initiatives, with a slightly different name, but they've been around since 1985. And Liz has been working tirelessly, and we are so fortunate to be able to work with her to help advocate for patients, to push through for the latest treatments to reach patients. So we're really delighted that you're both with us today. And as you will see from the slide here, Dr. Wraige has got some information that she's going to share with us about the landscape and how the treatments have developed, and how perhaps we can help people to be able to access them. So Elizabeth, over to you first.
Thank you very much, Kate. And I'm very grateful to MDUK for having invited me to talk here. And I will try and give you some of the context behind the treatments that are available, and hopefully some helpful information for people who are listening to this. So the first slide really just shows the timeline from the first description of spinal muscular atrophy by Verdnig and Hoffman, and that was in 1891. And you can see that it was just over 100 years later that the genetic defect was identified. And to explain, that was really understanding the cause of this condition, spinal muscular atrophy. And I will say just a little bit more about that in a minute. And it's only very recently that we've reached the point of having some medical treatments that are available and can change the course of this condition, which is really brings us into, I think, a very exciting era. And that's what I plan to talk about. And I've shown there the 3 treatments that I'm going to talk about today: Spinraza, Zolgensma and Risdiplam. Of these, only 2 of the treatments are currently available for prescription within the National Health Service, and that's Zolgensma and Spinraza. Risdiplam is still pending appraisal and hopefully approval. If it's possible to move on to the next slide, please. Just a little bit of background. It's very difficult to talk about a treatment of a condition without saying anything about the condition itself. And spinal muscular atrophy is a condition that causes muscle weakness, and that means that it's not possible to move in a normal way, or there is a loss of that ability to move in a normal way, and a failure to gain the usual motor milestones that we see infants and children acquiring. And at the bottom of that slide, you'll see that I've mentioned types 1, 2, and 3. And these are different forms of the same condition, spinal muscular atrophy, and refer to the different severities of the condition. There is a form of the condition called type 0 sometimes, which presents at birth and is the most severe form of this condition, where babies are substantially weak even before they're born. Type 1 spinal muscular atrophy is the most frequently occurring form of the condition. And in this type of SMA, the infants will never gain sufficient strength to be able to sit. And sadly, life expectancy is substantially shortened, with infants without any treatment not surviving beyond 1 or 2 years of life. Type 2 SMA is a milder form of the condition, where infants will have greater muscle strength and will be able to sit, but they won't have sufficient muscle strength to be able to stand. And type 3, those affected with type 3 SMA, will have sufficient strength to be able to stand and walk, although importantly, they may lose that ability, and often do lose that ability, later in childhood or in adult life. And the SMA affects around about 1 in 10,000 babies who are born. And it occurs because of a deficiency of a particular protein called SMN. And that deficiency of the protein comes about because of an error called a mutation in a particular gene called the SMN1 gene. Importantly, we have another gene called the SMN2 gene, which is almost identical to SMN1, but unfortunately it produces only very small amounts of the SMN protein. If you could move on to the next slide, please. And I'm now going to move on to talking about the treatments, and I'm of course happy to take questions at the end, and my colleague Dr. Fernandez will also be happy to take questions at the end regarding the condition itself as well as the treatments. The first thing I want to say about treatments is that we mustn't forget the importance of what we've come to call the standards of care for SMA, so that although we have medical treatments that we now use, these do not take over from the other aspects of the management of an infant, child, or even adult affected by SMA. And so these include measures that can be put in place to help support breathing. For our breathing, we rely on muscle strength. And in SMA, unfortunately, the breathing muscles are also affected, particularly so in type 1 SMA at an early stage. And we have measures that can help to support that, and that's generally through use of a type of ventilation called non-invasive ventilation, and the BiPAP refers to the most frequently used type of non-invasive ventilation. We also rely on muscles to enable us to feed safely. And again, unfortunately, particularly in type 1 SMA, the muscles for feeding are substantially weakened, and it may not be safe to feed through the normal mechanisms. And therefore, we may need to use forms of what we would call tube feeding. And sometimes that's a tube through the nose down into the stomach, but a more permanent solution is to have a tube directly into the stomach called a gastrostomy. And I put these in there because I think this support for breathing and feeding is something which has really substantially changed the outlook for people affected by SMA. And the other aspect which we mustn't forget is the importance of physiotherapy. And I have to say other types of therapy as well, which would include speech and language therapy and occupational therapy. But moving away now from those aspects of care which we have been employing on a regular basis for people affected by SMA and will continue to do. I'm going to move on now to the specific treatments. And if we can move on to the next slide, the first treatment to talk about is Spinraza or nusinersen. And this is available through the NHS for treatment of people affected by SMA types 1, 2, and 3. So that is the different severities of SMA. And it works by increasing the amount of SMN protein that is produced. And I didn't say earlier, but this protein is produced in the motor nerves. These are the nerves that send the signals to the muscles. And it works on the SMN2 gene. I don't know if you remember me saying that SMA comes about because of a coding error, spelling mistake in the SMN1 gene, but we have a second gene called SMN2, which is almost identical to SMN1, but just isn't as good at producing the protein. So Spinraza is working on that gene to try and make it better at producing the SMN protein. And this is available to us through what's called a managed access agreement with the NHS. And that managed access agreement is a form of contractual process that the treating physician would sign up to, the patient or the family would sign up to, and NHS agree to provide us with the financial reimbursement for the cost of the drug. And it encompasses within it a process of assessment. So it is a provision of this treatment for a time limited period, which in the case of Spinraza is 5 years, during which time information will be collected about how well people treated with Spinraza are responding to that treatment and whether or not there are any significant safety concerns. And the managed access agreement defines who affected by SMA can receive this treatment. So the first group who can receive the treatment are those with what we call symptomatic SMA. So these are people who are weak, who have muscle weakness as a result of SMA. They must have a genetically confirmed diagnosis. So that means we've shown that they have a coding error, spelling mistake in the SMN1 gene. And they must have type 1, 2, or 3 spinal muscular atrophy. They mustn't be ventilated for more than 16 hours a day for more than 21 consecutive days. So if they have an acute illness and are ventilated for a week, that doesn't mean that they cannot receive the treatment. They mustn't have a tracheostomy. So this is a tube directly into the windpipe to allow ventilation. It must be possible to give the treatment to them, and I'll explain a little bit more about how the treatment's given in a minute, but that term intrathecal injection is referring to the means by which we give the treatment. And they mustn't have contractures that would, so that's where the joints are affected and where you don't have the normal flexible movement at joints. They mustn't have that impairment to the level that we cannot assess how they're responding to the treatment. If we can move on, please, to the next slide. And the second group who are eligible for the treatment are those who don't yet have any problems with SMA. So they're not weak yet, but they have a genetic diagnosis that says that they're very likely to develop spinal, or that they will develop spinal muscular atrophy. And it goes on to give some information to the clinicians about exactly what the genetic information is needed there. If we can move on to next slide, please. And Spinraza is given by injection in the lower back. And this is what we call a lumbar puncture, and it's given directly into the fluid then that bathes the brain and the spinal cord. And you have to have 4 of these injections in the first 2 months, and then you need to have an injection every 4 months thereafter to continue to top up the effect of the treatment. And from the safety point of view, it's proven to be a very safe treatment so far. It is a new drug, but there haven't been any major safety concerns. Most of the side effects that occur relate to the actual injection itself, the lumbar puncture process, and the need that you may have for a general anaesthetic to do this. There is some monitoring that's recommended, and that's particularly blood tests and urine tests. And important to say that the best outcomes are if the treatment started early, and particularly if that's before the onset of any symptoms. If we can move to the next slide, please. And other things that are important to consider are that part of the managed access agreement tells us that anyone receiving the treatment must have an assessment, and that's a physiotherapy assessment and a medical assessment at least twice a year. We'd want to do this anyway for someone, an infant with SMA, but this is binding. If we don't do this, if they don't have their assessments, we can't continue to deliver the treatment. And the managed access agreement also gives us guidance on when the treatment should be stopped. And that's really if there's evidence that it's not actually working, so that if someone is not is actually deteriorating whilst they're on the treatment, then we shouldn't be continuing that. Or of course, if we're not able to continue to give those injections safely. If we can move on to the next slide, please. And I'm sorry, I'm racing through this because I'm aware of time. But I am going to move on to the next treatment now, which is Zolgensma. It does feel I've raced through Spinraza, and I'm very, very happy to take questions about it. So Zolgensma is the most recent treatment that's become available to us just earlier this year, with the first treatment in England being in May, and treatment in Scotland, I think also in May actually, but this is a gene replacement therapy. And so this also, just as with Spinraza, works by increasing the amount of the protein SMN in the motor nerves, but it does it in a different way. It's actually replacing the defective gene. The SMN1 gene is the gene that has the coding error in it in SMA, and Zolgensma replaces that. And it does it by packaging that gene together with a modified virus, and that virus is called AAV9. And that is then used to carry the Zolgensma into the motor nerves, and it gets into those motor nerves and it stays separate from our main genetic material, so that it sits outside our DNA, doesn't become incorporated into that, but it sits there and it produces the SMN protein. If we can move on to the next slide, please. And this is a treatment that is now available for babies and infants with children with SMA in the UK. And you may be familiar with an organisation called NICE, which is the National Institute for Clinical Excellence. And they have given guidance on which groups they feel Zolgensma should be provided for. And that's based on the evidence that is available from clinical trials. And they've said that this treatment should be available for any infant who's younger than 7 months, who has type 1 SMA that's been genetically confirmed. And all of that means that we've got a definite diagnosis of SMA from the genetic test, and that they are in that severely affected group of infants, they're not going to be able to sit on their own. And I've put there that they're not already on treatment. Okay, so that's a straightforward group to deliver the treatment to. If an infant, say aged 2 months, is diagnosed with SMA type 1 tomorrow and has a genetically confirmed diagnosis of this condition, provided they pass a few safety tests and we make sure it's safe to give them that treatment, they can receive that treatment without needing to do anything further. We don't need to consult with anyone else. If they're aged 7 to 12 months, and I mean the completion of 12 months, so taking it up to 13 months as they turn to 13 months, they can also receive that treatment, but it needs to be agreed by a national multidisciplinary team. So it needs to be taken to a group first who will review that, who will say, yes, we agree this infant should receive that treatment. And the reason that this has been put in there by NICE is because they've said that they feel in that group of children the evidence is not strong, and that the multidisciplinary team need to consider whether, if that infant receives the treatment, they are likely to gain the ability to sit. They have also said that infants receiving the treatment shouldn't be ventilated or have a tracheostomy. And NICE has also said that we can provide this treatment for any baby who has a genetic diagnosis of SMA, but has not yet developed symptoms with it. Really importantly, they've in bold and underlined there, I've said, and negative antibodies to AAV9. AAV9 is that virus that the gene is packaged with. And if you have antibodies to that virus, we wouldn't expect the treatment to work. It will be a treatment failure. So it should not be given to people with antibodies. So we must make sure you don't have those antibodies. Some of the infants who could benefit from Zolgensma might already be on treatment with Spinraza or with the other treatment, Risdiplam. And they just need to be discussed first in the national MDT before treatment can be approved. There is also a mechanism for giving the treatment outside of those recommendations of NICE. And that tells us that we can consider the treatment for any infant with type 1 SMA who weighs less than 21 kilograms. That's a little bit different to the approach taken in America, where they've used an age cutoff of 2 years. If we can move on to the next slide, please. And the treatment is given directly into a vein through what we call a cannula, which is a little plastic tube that's put in the vein. It takes about an hour for the infusion to give through, to be given. And a number of parents have said after the infusion, well, that was a bit underwhelming. And the actual process of the treatment itself is, putting the cannulas in can be a little bit more difficult, but actually giving the infusion is the straightforward part of all of this. The more tricky part of what we think of as the safety checks. And that's because Zolgensma does carry with it quite a number of potential what we call side effects, so problems that it can cause. And that's particularly with the liver, potentially with the heart, and with what we call the platelets, which are little things in our blood that help our blood to clot normally. And so we have to check all of those before we'll even agree to give the treatment to a baby. We also would not give this treatment if a baby has an infection at the time. And we advise caution about not giving the treatment too close to any vaccinations. If we can move on to the next slide. And because of these side effects, we need to give another treatment, and that's a steroid medicine called prednisolone. And that's to help keep those side effects to a minimum. And the steroids need to start before the Zolgensma is given, and they're going to continue for at least 2 to 3 months afterwards, potentially for longer. And it's important to monitor the side effects, not only for the Zolgensma, and that's through blood tests, which to begin with would be at least once a week, but also side effects of the steroids as well that we have to start to think about. And because of time, I'm not going into that in detail, but happy to answer things in questions. And just as with Spinraza, the treatment is most effective if it's given before the onset of any symptoms. And then if we can move on to my final slide, and apologies that it's just one slide for risdiplam, but this treatment is not yet available for us to prescribe through the NHS. We're waiting to hear back from NICE on this one. But it has been available through what's called an early access scheme, whereby the pharmaceutical firm have made it available to us. That's closed currently, but there'll be a number of infants who are on treatment with risdiplam. And it was made available for those with type 1 and type 2 SMA. So those who were more severely affected, who type 2 would be able to sit, but not to stand and walk. But importantly, only for those in those groups who couldn't receive either of the other treatments, Spinraza or Zolgensma. And this just works in a similar way to Spinraza. It increases the SMN protein by working on that second gene, the SMN2 gene. But unlike Spinraza, it can be given by mouth or through a tube. So it's more straightforward to give. I won't say any further at that stage. I'm going to stop talking because I may even have run over my time. But I know that Liz Ryburn may want to say something, but also very happy to answer questions, as is my colleague, Dr. Fernandez.
Fantastic. Thank you so much, Elizabeth. That was really, really helpful to really get the idea of all the different treatments, what they do and how they're delivered and how you could potentially access them. We'll come back to some questions in a minute maybe, but Liz, if I could turn to you for a moment. Elizabeth has already mentioned about NICE, and you and I and Rob and others have been involved in quite a lot of meetings with NICE over the years to help get these drugs to become available to patients. Could you explain a little bit about how your experiences of that and how it's worked, and how you've also supported families who've been involved in the discussions with NICE to get the treatments through?
Oh, thanks, Kate, and thanks for having me along today. The patient groups are very important for both NICE and the Scottish Regulatory Authority, the Scottish Medicines Consortium, because NICE wants to understand from the patient community what is the impact on you of this condition. That's really important, that they don't just look at it clinically, but they look across the board at, how seriously problematic is this condition. And they take that into account when they're considering whether or not to recommend a treatment for funding by the NHS. So our job as patient groups is to contact the community and to find out from people what is the impact on you? What are your views about this treatment? And we have often run surveys, and we've done this with MDUK. We've also done it with Treat SMA, so that we hear from people, we collate those surveys, and we can give that feedback to NICE. And we do that in a written submission. And we have written ours jointly with MDUK for both Zolgensma and risdiplam. And that's been really good, because we think it's good for NICE to see two united voices saying the same thing. The other thing we do is we are asked by NICE to nominate patient experts, and they want to hear from people who are living with the condition, what their experience of the condition is. They're not asking them to represent the community, they're asking them to talk about their own personal experiences, because again, to hear that directly, you're sitting in this sterile committee, you're economists, you've got all sorts of different roles there. To have a patient there or a parent of a patient who reminds them what this is like to live with is absolutely critical. So patient experts are there along with clinical experts, like Elizabeth might be at a committee meeting talking about their clinical experience, and they will answer all those clinical questions, and they of course can talk about the patients because they know them well, but there's nothing quite like the parent or the person themselves, if it's an adult, talking to the committee about what it's like. If possible, those committees like to hear from people who've also experienced the actual treatment. And for example, with risdiplam, recently with NICE, we were able to have an adult and a parent whose child has been on risdiplam talking to the committee about what impact that has had on them. And they really, really listen to that. When we nominate patient experts, MDUK and we look at who do we know, who is confident to talk in what can be actually a very, very daunting context. You've got a public gallery there as well, people from the community who are watching what you're saying. So you have this heavy responsibility. Am I saying the right thing? You know, am I remembering everything? And it can be really, really quite daunting. A lot of those committees get also very detailed information about the clinical aspects, the economic modelling, and they can be quite dense to follow. So again, that reminder of actually this is about me is really good. I've sometimes, well, in fact, I've always been nominated as well, merely because I can give an overview. But in the end, it's NICE that chooses who will be their patient experts. And they choose that from a 100-word profile about people. So I think that's in essence what we do. It can be long processes. There, you know, umpteen committee meetings, consultations, lots of writing, lots of toing and froing. But you know, I think we do as best we can at representing the patient community.
Fantastic, thanks, Liz. And I just, Elizabeth mentioned the managed access agreement, and there's also an oversight committee so there are people who sort of just check that things are working as they should be. And touch base from time to time. Again, you and I both represent our organisations and the community on that oversight committee, but I wondered if you could sort of just say a couple of words about that too.
Yes, again, I think that's really important. We meet every 6 months or so, and we're really looking at, you know, okay, this drug has been agreed, but is it really getting to people? And I think, as many in the community know, adult services have really struggled to get nusinersen out. So we've got on that committee representatives from the clinical community who have an expert clinical panel. We have NHS England, we have the patient groups and NICE, all looking at, is this actually working? And also, this is where SMA Reach comes in. SMA Reach is collating the information about the clinical outcomes, and they're letting this committee know, are we getting everybody to fill in these forms? Are we collecting the information we need? Is anything missing? So that by the time we get towards the end of the managed access agreement, we're in a good place for NICE to actually review clinical outcomes and economic cost effectiveness. And while we're talking about managed access oversight committee, I mean, the other thing I've been involved with MDUK and Treat as well is the rollout of things like the early access scheme for risdiplam, where trusts had to sign up individually to that. It was very much up to a trust. And we found some trusts were not keen, and we were really advocating very strongly for equity of access across the country. So we're quite busy behind the scenes. We don't particularly want to make a big public fuss about this. We find it much more effective usually to talk directly to the trusts, to talk to the clinicians about what are the issues, and then work with the clinicians to try and get change. And I think if Rob's there, I think we've been pretty successful on some of those EAM schemes in both Scotland and around the UK. And most trusts have come on board. 1 or 2, sadly, not yet. And that is much to the frustration of the clinicians there. And I think we really do need to say that clinicians are very keen to get these treatments out.
Super, thank you. Thanks, Liz. And Rob, is there anything you wanted to add to anything that Liz and Elizabeth have said so far?
Yeah, I think I'll just echo what Liz said on a couple of points. I think, yeah, absolutely. In where we've had individual trusts where the neuromuscular teams have been sort of frustrated about not being able to provide a treatment, we've definitely found that pushing a trust into a corner publicly doesn't serve patients as well as trying to work behind the scenes. So we try and keep the local patient community up to date as we can, but often we have to sort of do things sort of quietly in partnership with the clinicians. I think that links to another thing I was going to sort of agree with what Liz said. I mean, as well as working together as the different patient groups in order to try and kind of focus the patient voice, hopefully what we also do is make that coordination with the clinicians much more smooth, because that's really important. I think the patient groups and the clinicians have to work very closely together, because you've got the sort of two different sets of expertise and information, and I'd like to, hopefully, I'm seeing some nods, so I'm hoping this is right, but hopefully rather than having three different patient groups ask the same question about the same topic, actually when we work together, hopefully we streamline that a bit more. And then I think the final thing I'd really echo is just the value that the direct patient voice brings to the NICE and the SMC process. It was with another condition recently, which I was observing, where another neuromuscular condition, where the committee were sort of arguing about, well, not arguing, but debating the impact of a 1 meter or 2 meter movement or change of movement, and the parent on the just very matter of factly said, well, this is what 2 meters means to my life, and actually it means my son can get into his wheelchair himself or can get himself out of bed. And you can see the committee suddenly sort of, all right, yeah, it's not quite as analytical as meters, it's actually real life impact of a condition, and that's hugely powerful. And a kind of a big role for all patient groups is to support people to do that, but also make sure they don't feel vulnerable or exposed doing it. So we'll often work with patients behind the scenes who are very passionate and give really excellent insight, but aren't comfortable doing that in front of a committee, and that's completely normal and understandable. So it's about making sure we support people to do what they're comfortable with to strengthen the voice.
Fantastic, thank you very much. Now we've had a couple of questions that have come in about the treatment side of things. So maybe Elizabeth, I can turn to you, and in seemingly typical fashion for this this morning session, we have another individual who I haven't yet introduced you to, and I apologize for that, in Dr. Miguel Fernandez, who may also be able to speak to some of this. So I suppose one of the questions would be around the treatments that you talk about. How does one decide as a clinician or with the family what treatment? I mean, now there are two, there's a choice. How do you choose or decide which is the right treatment if you have a very young baby? Elizabeth, I don't know that you want to start.
I'm happy to answer that, unless Miguel would like to. I mean, from Miguel, would you like to answer this question? Because people might be bored with my voice.
No, not at all, but let's hear from Miguel.
Yeah, no worries. Happy to answer as well. Thanks, Elizabeth. So indeed, I think now our current practice is changing very quickly, because when we used to meet the families and moving from no treatments, from having one and now from having two on the table, then makes the conversations a little bit longer, and I wouldn't say difficult, but there are many other things and aspects to consider. So it's true now, our clinic decisions need to be more informed than ever for the families. So I think what we try is to explain what these treatments are, what the expectations from them are, and what we know from the science. I mean, I think it's fair that the families know what's been investigated, what's been researched, and what we know. We also try to share as much as we can what's not been published, which is our own experience. And I think that's also really helpful for most of our families to have direct information on how children do with this treatment or the other, what the side effects are, or what the profile of side effects, or what's not just in the technical prospects from the treatments, but also what we see in real life. And I think the families value that a lot as well. And I think ultimately, what we want is also is to make an individual decision for every patient, explaining why this treatment A or B could be better for you or not. Mm-hmm. But we all want to make the best for our children, for our patients. And that means that we want the best outcomes, but we also need to ensure that any treatment that is advised is safe for a child. So also when we present these treatments now, either nusinersen or Zolgensma, or for any other condition differently, we try to explain what the safety concerns are around it and why a treatment could be more advised than other. If at some point that is with a question or there is a choice between two, what would be the safest, or what would be with which one could we achieve the best outcome, also in terms of safety, which is also really important for patients. I don't know if Elizabeth wants to add anything to that.
I agree with what you've said, Miguel. I mean, I think we're looking at the on an individual basis at the safety and the effectiveness, and weighing those two up for the individual child. And I suppose our role as clinicians is to work with a family to furnish them with the information as best we can from, as Miguel says, our personal experience with the treatments, which of course is very limited, particularly with Zolgensma. When I say personal experience, I think Miguel and I would extend that to the fraternity of medicine. Are you allowed to say fraternity now? Sort of the medical world. So, you know, we learn from international collaborators as well, who do have, you know, a slightly longer experience with that. So there's that experience that you try and explain to the families, and the results from clinical trials and the safety signatures, and in helping work with them in a partnership way, I suppose, to decide what is the best treatment for their child.
Super. And talking about, you know, what's the best treatment, I mean, it seems to be that, you know, people can be on Spinraza and nusinersen, and then if they're obviously still young enough and fall within the criteria, could be considered for Zolgensma, but there's not necessarily that option, as far as I can understand, for them to go back onto the other treatment. You know, do you know why that might be? Is that something that might change?
I'll start with that, and then Elizabeth can continue. So what we know now from NICE guidance is that patients could opt for one or either treatment, but once you receive Zolgensma, and this is because we know that this is a treatment that is given as a one-off infusion, and that is expected to at least last for several years. That's what we know from clinical trials and from research, but also expected that could be a one-off for life, and we don't know that yet. Then the reason to have another treatment would not make sense, and that is more from the science point of view. Well, of course, our day-to-day and real-life experience might change within time, and we might come to a conclusion later on that some additional treatments are needed. But at this stage, this is at least what's been planned, and this is what we know so far. I think accumulated experience on more patients on Zolgensma will give further evidence on which of these patients might need an additional treatment, because some of them might need it and some of them might not.
Sure. So
the eligibility for further treatments need to be assessed, but I think we need still to have more data on that. I think if I think just from the physiology, from what the mechanisms, ultimately both of them try to enhance the production of this SMN protein. So I think the rationale behind it is, if you already have enough SMN protein, even if you top it up, or if you want to have more of that protein, possibly that will not change much of the outcome. And that's it. And that is one of the reasons why this is so far not the idea. Things might change in the future, but this is and we might need to think of alternative treatments that look at providing other things for the motor neurons that are not SMN, just SMN protein.
Sure.
And that's been researched in different lines of treatments. I don't know if that makes sense.
Yeah, no, that's very helpful.
I think it's important to know that, as Elizabeth mentioned, that these treatments are most effective when given early.
Mm-hmm.
And this is because the outcomes are highly dependent on the non-damaged motor neurons at the point of treatment.
Yeah.
So what we are injecting is something that produces the protein, but unfortunately, it will not repair the damaged motor neurons.
Yeah.
And this is, I think, the key point to understand why two treatments might still not give an additional benefit.
Yeah.
But we are still learning about this. So
yeah.
I might be changing my words in a couple of years' time.
Yeah, fantastic. And I guess one final question, perhaps for this session, perhaps either Miguel or Elizabeth would want to touch on this again. It's perhaps looking at that. You know, at the moment we've got very strict boundaries in which we can you can provide the treatments to patients. But do you see a time perhaps when you might be able to give Zolgensma to children who are above 21 kilograms, or if you're thinking on the aged range, older or something? You know, do you think that could come in with time? I mean, at the moment, I guess, going back to what you're saying, Miguel, about the evidence that we have, there isn't any, but that might change, I guess, with time.
There are certainly efforts to research that and to investigate whether that is a suitable treatment for older children. And there will be clinical trials later on, possibly this year, looking at this possibility. I think the most important thing that we're looking at is safety. As already what we know is that bigger patients, older patients, tend to have more side effects. And what we wouldn't like is for someone that is already stable with that condition and having some stability or not progressing much, what we wouldn't like is to stop that from happening because they've got some safety problems with the drug that we are given. So that's definitely going to be looked at, but there's limited experience, and I think we still need a lot more about safety. Sure. Also, we know that the likelihood of having positive antibodies is bigger when you're older.
Yeah.
So there might be more limited number of children that can receive these treatments above the age of 2. Elizabeth,
I don't think I have anything to add to that. I think that's right. I mean, I think safety foremost, and I think a key thing is that the amount of the gene packaged with virus that you have to inject is based on body weight, and think of it a little bit like an immunization, but giving an awful lot more. And most people are familiar with the fact that when you have an immunization, you often get a fever, feel unwell, have sore arm and so on afterwards. You're stirring up the immune system. When you give Zolgensma, you're giving so much more, and you are really stirring things up. And that's why we need to give the steroids. But for heavier people, you need even more of it. And so there's the potential side effects and safety concerns mount. And I think, you know, we have to look to clinical trials and evidence.
Brilliant. Fantastic. Well, thank you to Liz and to Miguel and to Elizabeth for your insight. And I think probably now is an ideal moment to move on to the final session for this morning. And I will hand over to Rob to introduce the Living with SMA session.
Thank you so much, Kate, and yeah, thank you to everyone who's spoken so far. I think it's a real sign of the sort of the pace of progress that's being made in sort of treatments for SMA. That this time last year we had a very short section just on Spinraza, so there really is a kind of wealth of stuff coming through. And thank you to Elizabeth and Miguel for explaining it so accessibly. I think we'll definitely be using that on our website if we can. We'll talk to you after this, because that was a fantastic run through. So yeah, this final part of the seminar is around sort of living with SMA and the sort of care that might be provided. As Kate said, I'll have to retrospectively introduce Miguel. So I'll introduce the panel for this section, and then I'll invite each one to say a few words before we then sort of move into sort of question and discussion. We've got about half an hour left. So we've already heard from Dr. Miguel Fernandez, but he completed medical training in Spain as a paediatrician, followed by completion of training as a paediatric neurologist in one of the largest children's hospitals in the country. He developed an interest in neuromuscular disorders and was granted with a fellowship by the European Paediatric Neurology Society to further that interest. He came to the UK and has been part of the neuromuscular team at the Evelina, I think, for the past 3 years, working with Dr. Wraige, and has recently been appointed as a consultant in the team. Pleased to also be joined by Felicity Van, a senior specialist paediatric physiotherapist, also at the Evelina. Felicity works in neuromuscular paediatric physiotherapy and is involved in both neuromuscular research and patient care. And before joining the Evelina in 2016, Felicity worked at Birmingham's Children's Hospital across different disciplines. And we're also joined by Natalie Smith. So we've broken the Evelina pattern, and is a neuromuscular clinical nurse specialist at Great Ormond Street Hospital for Children. She has a background in children's intensive care and is the lead nurse for the Trust for SMA, although works across all other neuromuscular conditions. And she's worked with the team at GOSH for since 2017. And delighted that Liz is also with us, as well as Dr. Wraige staying with us as well. And any other panelists who want to jump in on other questions as they come up are very welcome. Natalie, I wonder if I can come to you first. Just really interested in hearing more about the role of a clinical nurse specialist in supporting infants with SMA, and perhaps a little bit about the kind of the wider team that's involved in their care and the kind of things you support families with.
Yeah, this is I always find this a really difficult question. What do you do? And you sit there and you start to write what you do, and you think, how do I explain this to everyone? So I've written a little bit, and we'll see if you all agree about this is what the CNS does. But really, for me, it's changed over the last 5 years. I was lucky enough to come into the neuromuscular service right at the implementation of the extended access program for NUSA nursing, which means that I met a group of about 30 children, all at various stages of their disease progression, who started on Spinraza. So my role over the last 5 years has been getting to know these families, and it's been really interesting for me to watch the difference in children who are potentially dosed at 2 weeks old versus dosed at 5 months old, and how they are now coping. It's really important that we're there from the beginning, from the point of diagnosis, which is a really scary and overwhelming time. So we sort of help families focus on what's important for themselves at that moment in time. As you're all aware, there's certain things like access to disability living allowance, education, healthcare plans for schools. So for my original cohort of about 30 children, they're all approaching school now. I'm doing some work with SMA UK to try and develop some patient-specific educational information about schooling, because what we're finding with SMA is that these children are all articulating themselves really, really well. But particularly with type 1, the medical needs are so high that we're getting a lot of pushback from schools, and wanting these children to go more in the direction of special school, and I'll put that in brackets. So that's one of the projects we're working on at the moment. Having such a large cohort of patients, I've been able to find common themes between certain patients at certain periods of time, feed that back to clinicians, and again, that all feeds back into the NHS and NICE's agreement for the managed access agreement for NUSA nursing. So we're looking at things like financial costs of caring for children in their own homes. And that also links to newborn screening, I'm finding, because if we can get newborn screening approved, hopefully before 2025, which is something that I heard in the grapevine, which shocked me after gene therapy being announced, the earlier we can treat, the better it is. And there's a huge part of the CNS role is managing expectations for families who see really promising videos online of children who've had gene therapy, walking around holding a bike in their hand, and they you know, maybe they come into us at 10 months old, and it's managing expectations and being really realistic about what we know. And as Miguel and Elizabeth touched on so nicely, being open and honest about the things that we don't know and the things that we're going to learn together over the years. So I think that's a little, I obviously manage patient and give clinical advice in and out of the hospital. I run our nursing list, and we're looking at procedural anxiety. So a little bit of everything, sort of a one-stop shop.
Thanks, Natalie. That's a very good overview, actually, I think. Also, it's interesting you mentioned screening. If we had another 3 hours for this session, we'd explore some of the other things that we do. But yeah, that's just sort of, I suspect that'll be this time next year. We'll be talking about where things are at with screening and things like that. So that's an interesting one to raise. Felicity, I'm going to come to you now, and I think we've actually got a slide that we may play whilst you speak, although there might be a technical issue, so we'll find out. We'll see how we go. But yeah, it'd be interesting to really hear about why is physiotherapy so important for SMA and the kind of support that you provide as a specialist physiotherapist.
Thanks, Rob. Yeah, I think we can leave the slide to the end and see if it works. I'll give a bit of an overview to start with. I think I'm probably quite biased, but I think the physio is a key member of the MDT, alongside everyone else we've already heard from, the sort of consultants, the nurse specialists, but also the other therapists that Dr. Wraige mentioned, speech and language therapy, occupational therapy. And then you've not just got myself as a sort of a physiotherapist at one of our centres, but also the physios in the community. All of them have a huge input on the children with SMA. I think in general, the main goal of a physiotherapist, especially a paediatric physio, is to promote best quality of life. And so for our children with SMA, we want to try and encourage as much function and participation in the kind of activities that they want to do, and the activities that maybe they should be doing for their age group if they didn't have SMA. And I think that's really exciting, because it's something that we hadn't been able to think about much previously before having any treatment. The physios didn't have an active role, because the idea of sending a child with SMA type 1 to school was not really an option, because of the difficulties either with how poorly they were from a respiratory side of things, or even just positioning and management. And now most of our children go to nursery, go to school, they do lovely things, they go on holiday, they join clubs, all sorts of things. And we as physios need to try and facilitate that as much as we can, because as much as they're being treated, they are showing improvements in at different rates, and every child is different, and it might be that everyone has a different way of accessing something. We're not clicking our fingers and saying that they unfortunately are sort of developing at the same rate as a normal child, but they will need some help to get there. And that's where I think we as physios come in. I think our key focus has to be that we try and maintain the range of movement, because a lot of our children, possibly some of them that either haven't had treatment from early ages, or even those who have, they're all at risk because of the lack of normal movement of contractures and muscles getting tighter, because they're not moving their joints through range. So when you're not moving your sort of elbow through range or your knee through range actively, regularly, then your muscles are likely to get tighter, and tightness then leads to a contracture, and a contracture is a problem because it means that the muscle can then no longer lengthen. And if you have a muscle that's got tight, it might make something that you want to do, if you've achieved something from a treatment, more difficult. So for example, if you've got tightness at your knees, then trying to use a standing frame, or trying to possibly progress to more than a standing frame, could be really quite difficult if actually you've got that tightness and then contracture at your knees. So we as physios work quite closely with the community physios and with parents to educate on contracture management. So that's one of our definite key things, but also with the orthotists to help them, because sometimes there might be splints and things that they could sort of support with. So potentially, again, going back to knees, we could talk about gaiters and splints they might wear at night time, but also active splints, sort of ankle splints that they might wear in the daytime. Lots of different things, but we are there as physios to lead on that, really. And then the other thing we might think about is other kind of orthotics that might help their function and try as much as possible and reduce the potential sort of negative side effects of having a weak core. Potentially, maybe you might get a scoliosis, as a lot of our children would, especially the type 1s and type 2s would be prone to getting a scoliosis because their spine is put under pressure when they're sitting, and they don't have the core stability to support it. So if we can provide a spinal jacket, and that's all driven by the physios as to as and when that's appropriate, and also we will also advise parents on when actually it's appropriate to start sitting. And I think that's one thing that parents question a lot of is when should we be starting to sit with our child, and it's a really difficult one, because in a normally developing child you'd expect sitting to sort of be achieved around the 5 to 6 month age bracket, but actually we will hold off usually a little bit, and we will do lots of other positions. And it's one of our key things we push a lot and we talk a lot about, because we want to try and again reduce the potential negative implications of their diagnosis, which could be a scoliosis. So we might then think about sitting later, and when we do sit, providing a spinal jacket through the orthotists. I think that's sort of a general brief summary, but the main thing I wanted to say is that I think the key thing about physio is it has to be quite fun. So I have if that slide will work, I've got some ideas of different physio things that some of our parents have sort of sent me. So we've got a few, if it will play, you might see what happens. And it might be that each video needs independently clicking to play, but we'll see if they play. But I can just describe if not. So if you can see, you've got a child in a whizzy bug, which is the red little car on the top right of your screen, and he has type 1, and he is able to chase a bird at the park, which is something really quite fun and active for a 3-year-old child to be able to do. And that's how old he was in that picture. And I think it's really important that we facilitated as physios, alongside his community physios, and his occupational therapists, the acquirement of the seating, the ability to spend time in those positions, and then to be able to enjoy that sort of activity. The one in the middle, our young lady there, she also has type 1, and she is riding a trike, just like riding a bike if you were sort of 6 years old, which is really lovely. And she gets a little bit of support from dad at the back, but she actually does propel the pedals forwards. The boy who's with his dog, he is sitting with his spinal jacket on, and he is playing a game where he drops a car. So the idea that he could lift his hand up to that point and drop a car into a tunnel, and the dog then goes and gets it. And it's just a fun game that a child can play. The other ones would flip up if we played them, but the other boy is just playing on a mat. He looks like he's lying on his tummy at the moment, but he's rolling himself over to get the toy that's behind him, bringing it back to give to his mother, and rolling back again to get something else. Again, a really nice normal activity. And it's the same child standing in a standing frame, and when it plays, he pops bubbles and enjoys popping bubbles. Again, a really nice normal activity. And the last older teenager, she's actually doing some boxing with her sitting in her chair. She's doing some boxing with her upper limbs, so she's got gravity eliminated using her slings, but she's actually doing a bit of boxing, working out a bit of anger management and having a bit of fun at the same time. So I think all of these things are key things that we as physios can enable. I would be wrong not to mention respiratory physio as well, but it's not what I cover personally. We have respiratory physios who would try and look at sort of maintaining good respiratory function and preventing the respiratory problems that unfortunately we know are associated with SMA. So I'd let them explain that a little bit more depth, but as an active sort of movement physio, I'm fully aware of all the things, and I think we try and maintain that through cardiovascular activity, but they will also look at prophylactic things such as BiPAP and cough assist that might be necessary for most of our children.
Thanks, Felicity. That's fantastic. A really useful overview, and kind of interesting, opening up another area about the specialisms within physiotherapy to help someone with SMA. And I'll probably come to Miguel and Elizabeth on that in a second. But before I do, I was struck, Natalie, that some of the issues that you support people with certainly are things that come through to the MDUK helpline, and presumably Liz Ryburn, are things that SMA UK support people with as well. So yeah, it'd be really interesting to hear from you, Liz Ryburn, about the kind of things that families will come to you with about sort of queries and support for their children.
Yeah, thanks, Rob. I mean, really interesting to hear everybody. I mean, I think clinical teams are really supportive of families and take them through. But there are still some families, it's an overwhelming diagnosis, and the possibility of talking to an independent charity. We've got a small team of very experienced staff. We've been around for a long time. So you're talking to somebody who does understand, and it's that emotional support initially that can be extremely important. And in non-COVID times, our outreach workers will go and make a home visit. And again, you know, being in somebody's, you know, kitchen, having a really long talk, that can be so helpful. And it's not just this team, there's that whole SMA community there as well. We, you know, parents, grandparents, young adults, we're in touch with them as our MDUK, and it's a community that's incredibly supportive. So we're able to produce a podcast where we've got a couple of young people's parents ask us anything. We can introduce people to networks, and I think that's extremely important. I would say, again, incredibly resilient families on the whole, sort things out themselves, you know, really want to do everything for their children, but they hit brick walls. I mean, brick walls of, you can't get equipment, can't get care packages. You might be finding that you can't get the access to the nursery or school that you really, really wanted. So again, we can support that family, and it'll often be about explaining the condition and just giving them a bit more ammunition to advocate for themselves as to what they're wanting. And again, you know, because it's UK wide, not everybody has got a fantastic Gosh and Evelina on their doorstep. And it's particularly difficult for people who are in the more rural communities. So that in a quick nutshell, because I'm very aware of the time, Rob, but that's, and I think it's probably similar work to you, but we just focus on SMA. And oh, one plug for us, we have a fantastic area on our website called Living with SMA, which is full of resources. And we're putting more and more personal stories and video clips on there. And, you know, we hope that'll mean people can go and find things themselves, and then they can ask MDUK, us, any other organisation for the additional help they need as well.
Thanks, Liz. That's fantastic. I'm going to direct this initially to Elizabeth and Miguel, but I suspect it may cut across a lot more panelists actually. So, and it's a two-part question because I'm going to try and combine it with one that's come in. So, first of all, Elizabeth, in your presentation, right at the start, you mentioned sort of standards of care as a sort of concept. It'd be really interesting to hear from you, Miguel, about all the different elements that you as the consultants have to kind of build around a patient with SMA and how that's coordinated. And then we had a really good question has come in around difference between different countries. So just interested about whether there's international standards of care. And I know that came up in the research section as well, but that would be useful to touch on as well about why are there differences across different sort of countries?
I'm happy to start answering that. So I think when we meet someone who's affected by SMA, we have to not focus just on as neuromuscular clinicians, we have to not just focus on the medical diagnosis itself and the medical treatments that we now have available. The child is a whole person, and they're part of a family that is a whole as well, and so we have to think about all of that, and there are many different aspects we have to think about, and I'll try and sort of break it down a little bit in terms of the approach. So I think the first thing is, you know, I'm a medical doctor, so I am going to have think in a medical way. It would be wrong if I didn't actually, and I will first off be thinking, is the diagnosis right? Do the family understand the diagnosis? And then thinking about the different meanings of that diagnosis and how it impacts, and what we need to do in order to try and help that child and that family. So one aspect of that will be the straightforward, the medical aspect of it. What's the right treatment for this child? And we've talked about that. That's the medical treatment aspect, but you cannot do that in isolation. So we need to really do a very thorough assessment to understand how the condition is affecting that individual child. So we would look not only at their movement, whether they are able to do things like lifting their head and rolling and even sitting, but we would also look at the breathing muscles and the feeding muscles. And then we would go beyond that, and we would think about all of those things that most of us take for granted, you know, whether we are able to open bowels okay, whether we are able to get adequate nutrition, whether sleep is good quality. You have to think about all those added factors. And if you identify problems in any of those areas, and some of that's going to require specialist investigations. If I'm thinking about the breathing, for example, I'm going to have a look at a baby, I'm going to talk to the parents, I'm going to get an idea of to what extent breathing muscles are affected, but I'm also going to want some form of investigation to give me a quantified result, if you like. How much of a problem is that? How affected are the breathing muscles? So that might mean that I get what's called a sleep test, which measures oxygen and carbon dioxide levels. With the feeding, I can talk to the family, I can watch a baby feeding, understand whether there are some problems there. But again, I'm going to want to get a more in-depth understanding of that. So I'm going to ask a speech and language therapist to have a look and see what's happening when a baby's feeding, and whether actually they're going to be able to get enough nutrition that way, whether it's safe for them to feed that way, or whether we need to think about other measures. I may well want to do a blood test to look at the overview of the nutrition. Is the liver working okay, heart working okay? That might be very important, particularly with some of the medical treatments. Particularly, no, this isn't relevant to the young infant, but as for a child affected with SMA, as they're a little older, we have to really think about the development of the bone strength, because to develop strong bones, we rely on strong muscles for part of that. And if you have fragile bones, then you may be more at risk of breaking a bone if you do have an injury. So we have to start to think about how we look at that aspect. There are some other potential medical problems that can go along with SMA. That includes things like the way we control our sugar levels, glucose levels, and some infants with SMA can be prone to dips in their sugar levels. So we may have to think about those aspects as well. And then we need to think about that whole quality of life, which Felicity has talked about. That's really the involvement of the wider team with physiotherapists, occupational therapists, nursing, psychology. You know, what can we do to help the infant, child, the family to be having a good quality of life? I think sometimes as a clinician sitting in a clinic room and someone coming to see me or going up to a ward to visit a child, it's a very artificial situation, and you can very easily fall into the trap of forgetting that people live a life outside those walls, and actually that's what's really important, that they can do that if they want to go to the beach for the day, they can do that. If they want to go on a holiday, they can do that. And how do they do that? So it's thinking about all those added aspects, and that can come down to what equipment do we need to provide to enable them to do that in a safe way with their child, and to make things as easy as possible. I don't know if that's answered the question. I haven't.
Well, yeah, that's a fantastic overview. When we set these sessions up, we started by mapping. Well, let's get a representation from every discipline that's involved, and you suddenly realize your panel is going to be 27 people long, and you can't do it. So I think you've really captured that sort of very, very well. I guess the other part of the question was just about international comparison and standards of care would be interesting to touch on.
Yeah, so I mean we do have published in standards of care, which are international standards of care. So there are going to be differences across nations. I mean, you know, even with published standards of care, I think you can take those standards of care and say, look, this is the bedrock for what we should all be doing. This is what people have agreed is the right way to approach things. But I suppose somebody might look at a particular aspect of that and it doesn't work within their own setting, within their country. And so they might have to think, well, actually, okay, we can't do it quite like that. So is there another way that we can approach this? And I think it's also important to say that some of the elements of the standards of care are very much based on, you know, evidence, and it would be very difficult to say that that's not the right thing to be doing. But other aspects of the standards of care are what professionals as a group, perhaps with involvement from families, have said, actually, we don't have the firm evidence to say that this is how it should be done, but we think this is the best way to do it. And so sometimes when you look at that, as I say, it might be difficult for some centres, some countries, to actually do it as it's written. And so there might be some variation on that. And I think we have to accept that some variation is not necessarily a bad thing. And also that if you never have that challenging of something like standards of care, we'll never move forward. We would stand still, and that also wouldn't be right. Sometimes you do have to come back and look at something and say, well, that's how we've been doing it for the last 10 years. But actually, given what we know now, is that the right way to continue doing it? Things evolve. I think in terms of what's available in different countries, and with, you know, particularly thinking about medical treatments, it does move at a different pace. I mean, we saw that with nusinersen and Spinraza, with, you know, some countries introducing it at a much earlier rate than other countries, and we see the same with Zolgensma, and I think that's, in an ideal world, we would not have that. We would not have any differences between countries. And I suppose that applies not just to treatments for SMA, but for everything. But unfortunately, we do live, you know, in a world where we can't escape the fact that there are going to be those differences. And in this country, well, up until recently, we had the European machinery for assessment of drugs, but we additionally had our NHS that had to approve the funding of drugs. Now, of course, we don't. You have to have the European. We're not part of Europe since Brexit. We have our own mechanism for assessing whether drugs are safe and should be licensed or not. We still have that NHS system that has to look at the cost benefit of treatments. What is the gain from the treatment? Is it a safe treatment? I think it's important to acknowledge, actually, that I think we often, a lot of people see this as a negative, that it's there to keep things away from people. It's all about cost. But I think actually really key component of all of these regulatory side of things is looking at the safety as well. So it's weighing up the benefits from a treatment against any risks of the treatment, and so there is a really important component to that. Unfortunately, it can sometimes lead to delays in things getting out there as treatments, and you know, that really we don't want, and we want to try and get things from, you know, clinical trial through to treatment available as quickly and swiftly as possible. But I think, you know, that we do have different systems that operate in different countries. So in America, they have the FDA that looks at their drugs, and they've said you can use Zolgensma up to the age of 2 years. In Europe, they've taken a different approach. They've said up to 21 kilograms, and they've not put an age cutoff on it. And I think we can't escape the fact that there are going to be differences that will come out internationally.
Thank you. That brings us to the end of the session. Actually, it's been a hugely fascinating session, and we've covered a lot of ground. So I think we may end up repeating this later in the year, I think, to try and cover some of the territory we didn't get to. But thank you so much to all of our panelists. Thank you to those who've joined as part of the discussion as well, and as attendees. I am definitely going to watch this one back, because there's been so much rich information presented very clearly that once this goes on our website over the next couple of days, do look at this again. So yeah, huge thanks to everyone involved, to our sponsors, and thank you very much for giving up your time. And yeah, thank you for joining us, and have a good rest of the day, and indeed the week. Take care, everybody. Bye-bye.
Thanks. Bye-bye.
Bye-bye.